Thank you so much. Yeah. So I think it's about 8 minutes, so I would just have time to flip through my slides, I guess. Yeah. So I'm going to talk to you on the current perspectives of tissue addition, keratoplasty here, no financial interest here. So one thing when we are talking about lenticule-related surgeries, so one we have lenticule extraction procedures which are refractive, and we have tissue addition procedures using lenticules here. And I think I wouldn't delve into the nomenclature part of it and directly take you on to tissue replacement procedures here. So we'll skip the initial parts of the lenticule extraction refractive modules here. So I would request you to go and refer to, if you are interested, there's a comprehensive review in the latest edition of Indian Journal of Ophthalmology, which does give you a comprehensive overview of current literature on lenticule addition, keratoplasty here. So from what we see is most of the literature, it's not much, but whatever we have, I think lenticule addition keratoplasty is here to stay, and it is evolving, and we probably need to have a little more understanding of how this is going to influence, or what is the role it's going to occupy in the management of our keratoconus spaces. That's largely where we are going to use it, because it's going to improve the tectonic integrity. It's going to thicken our corneas here, and it's probably going to bring out a refractive change. So whether it's going to give a visual outcome that is acceptable, and it's going to replace replacement keratoplasty tissue replacement keratoplasty procedures is something which we will probably understand in the coming years here. When you look at tissue addition keratoplasties, what we largely have is the first three. We'll have the Bowman's layer transplantation, the corneal allogenic intrastromal ring segment implantation, the KERS, and the femtosecond intrastromal lenticular and the intrastromal keratoplasty there, and the last one. So these are the three replacement procedures, tissue replacement procedures, which we could probably adopt in management of our keratoconus cases here. So when we look at Bowman's layer transplantation, it is a novel approach, but it has a learning curve here. The tissue preparation is slightly more challenging than a routine keratoplasty, and whatever we have in terms of results and success rate is about 70 to 75% of success rate in helping to arrest a progressive keratoconus, or in helping to give a visual outcome that is acceptable in these cases here. Some of the complications here is landing up with perforations and infections as expected when we are doing a lamellar procedure. So literature is not replete with lot of articles on this. We currently just have about 3 or 4 authors who have shared our experiences, and when you look at long-term results of Bowman's layer transplantation for advanced keratoconus, we have results which are over 18 months follow-ups. We have one other larger one which talk about their 5-year results here, and most have indicated a success rate close to about 85% in 5 years post-operative, and they do advocate this as a replicable procedure or a reliable procedure here. I per se do not have an experience with Bowman's layer transplantation. A Bowman's layer onlay grafting for keratoconus is also a variation which has been described with just about one study on 20 eyes, and which also is claimed to produce acceptable results in these patients here. So when you look at the other tissue addition keratoplasty, it's not per se an 8 millimeter diameter graft, but then you're looking at a procedure where you instead of intacts, you're going to look at using intrastromal ring segments which are created using allogenic tissue here by a specially designed trephine, and these are inserted onto a particular femtosecond created channel here, and you can decide of how you want to put asymmetric or asymmetric ring segments here, and there is a marker onto which it's placed on depending on what is the length you would want to do. There are a few variations again described by Susan Jacob and her group, and And it's quite interesting to look at their results, and they do claim, this is some of her postoperative pictures which Susan has shared with me, and she does say that there's a significant amount of flattening which one can obtain even in advanced cases of keratoconus. And there are only 2 large-scale studies which talk about the reasonable follow-up methodology, and it is being advocated as one of the methods where you could use these human allogenic ring segments for producing flattening of progressive keratoconus, and can combine it with collagen cross-linking as well. Coming to the third, which I think there are pockets of people across the world who are probably looking at intrastromal keratoplasty, where a femtosecond created channel in the in the host keratoconic cornea, and the lenticule, which is then cut out using a microkeratome or fashioned using a femtosecond laser itself, is then used is implanted into the lamellar dissection here, and this will help to cause the tissue adhesion here. So I'm sorry, I think I'm not using my laptop, so this is not in well. Here is the femtosecond channel which is created in the donor keratoconic cornea here, and this is a progressive case of keratoconus here. The Moria microkeratome is used to fashion out a donor lenticule about 200 microns here, and this lenticule is then placed in the femtosecond channel which is created in the donor cornea. So that's the lenticule which is implanted as a lenticule adhesion keratoplasty, alcohol aided removal of the keratoconic cornea, and this is then treated with exposed to collagen cross-linking here. So I call this keratoconus plus, and I'll just share a few of my initial results of 10 patients. I have about a year's follow-up for all of them here, and just a peek into the results which I have obtained in these cases. These are the follow-up pictures, the amount of flattening which have been induced during the follow-up, and as you can look at the linear graphs here, 5 out of the 10 patients had improvement in their unaided visual acuity in the post-op period, and 7 had improvement in their best corrected visual acuity here, and all these show that they do bring a change in the corneal curvature here. Watching their IOP is something you need to look at, because you need to look at the biomechanically corrected IOP in these patients. Well, this procedure does bring about structural integrity, does cause a significant corneal flattening in these patients, and does work in producing stability of these corneas and the change in some of the corvus biomechanical parameters here. Visual acuity also showed a significant, but I didn't find a significant change in the corneal aberration. So currently probably it just is an alternative to those cases of progressive keratoconus where the cornea is too thin here and it's not amenable to the conventional protocols, and you can probably use it as an alternative and combine it with collagen cross-linking. I'll stop here and thank you for your patient listening.
If you don't mention one quick question, so you take lenticule with Bowman layer, yeah?
Yes, so this lenticule comprises of Bowman's with anterior
and some stroma.
Yes,
and the idea is probably to increase the mechanical or biomechanical strength of the lenticule.
Sort of causes the tectonic integrity sort of improves. So we took those cases which are not amenable to collagen cross-linking because they've gone thin beyond the face, and we created a femtosecond channel here, and then implanted these lenticles created using the microkeratome, and the donor cut diameter was around 8.5 to 8.9 millimeters into these channels here, and we looked at what is the refractive change this is producing here. So it does cause an acceptable flattening, but patients would still need contact lenses after that, but then the quality of vision is probably better. But currently with the available modules, the eye trace is the only one where you can sort of quantify to see how their MPFs are changing here. So quantifying, and patients do say their quality of vision is better than what they had without an intervention. But vis-a-vis when you compare to DALK, I still find DALK is the better procedure. You have only a single interface here, and I still am more confident offering a DALK. So I did see this procedure being adopted by a few, and they did claim, so we thought we need to do a systematic evaluation for us to have an understanding how it really causes changes in both in the anterior and the posterior curvatures, and how the visual acuity changes. I still feel it's an alternative modality where you probably don't want to take them for a patient is not willing for a dark, patient doesn't want to wear a contact lenses, then you use these as an alternative, and it does produce an improvement in visual acuity, but the best possible quality is with the dark. Not
And
comparable. I have a patient who has an intrastromal in the right and the dark in the other. He's dark, he's 6'9" unaided. In this, he's gone to about 6'18", and with glasses improves to about 6'9". But the quality of vision, he's not very happy.
And I believe this is a category of patients without central corneal scarring, so it's with clear cornea.
Yes, clean corneas without
Okay.
scarring.